Good afternoon.
You did great.
Welcome to Battle of the Titans. We had a really incredible day. We heard from three incredibly talented team of surgeons, restorative dentists, clinicians, and scientists and researchers who presented three different approaches to managing the transition from teeth to implant. Each of them laid out their clinical cases and their very meticulous documentation over time. And it's really a great opportunity for us to now have all three teams participate in this panel discussion so that the audience can see the comparison and contrast among these three different approaches. So what I would like to do is to just actually go through what Professor Boozer laid out today as some criteria for assessment of these techniques. He laid out these criteria very nicely, and I think that would be a very nice framework to discuss these different approaches. So when we look at the evidence that we have for these three different approaches, all three approaches have basically been documented in the form of case series. And what we really are lacking in the literature is randomized controlled clinical trials, especially side-to-side comparisons. We've had comparisons of some approaches of delayed versus immediate, but we really have not had side-by-side comparisons. So I think it'll be incumbent on each of you to compare what we have as the level of evidence for each of the three techniques and whether or not we should basically rely on the case series as evidence to proceed for the clinicians. Who would like to take this on? Yes.
I probably have to disappoint you because I strongly believe that in this field of application of dental implants, to perform RCTs is completely unethical. Because when we know given risk factors, documented risk factors, take patients and then without judging the risk factors, go into randomization, then we harm patients on purpose. And I can tell you in Bern, no ethical committee would approve such a protocol. So therefore, I think we have to stop this nonsense that for surgical techniques that we are asking for RCTs for scientific documentation. I think proper case series studies are sufficient when we have the long-term data to say that the technique works. We don't have to say it works better than anything else. I think that's not necessary. I think we need at least prospective case series studies on a certain number of patients, certain duration, to have let's say, an opinion about the efficacy of these procedures.
Does everyone agree with that? That's quite a provocative statement.
Yes.
To say that RCTs are not necessarily the gold standard because they're basically considered the level 1 evidence.
Yeah, but you see, this comes from pharmaceutical research where you compare different medications or so. And you can do that also in the prosthetic field when you do by randomization a screw retained versus a cemented restoration, different abutment materials. But for example, you cannot do that when you compare immediate versus early placement, when we all know a non-intact facial bone wall is a high risk factor for such a procedure, and therefore it's unethical and we should stop the stupidity. What do you mean?
Well, I didn't say a word. I'm just. I actually agree with Danny. I think it's very hard. Some of the procedures that we would be randomizing are not really validated yet, except for a few people, such as we see here today. And therein lies the problem, because if you have a patient in your chair and this is someone that you have to decide what to do, they're going to be slightly different. Like you said, the parameters are different that they're presenting with buccal plate, no buccal plate, thick, thin for some of us. But we're first learning what might have to be randomized. I think like the PET's only been handled by a handful of expert clinicians. And other people have tried it and didn't like it. Other people have and just haven't done a lot of them. Why? What's for the masses? What does the so-called average clinician do? And I think that's what we're all seeking, how to make it simpler, easier, faster. But to randomize it is going to be very, very difficult without potentially causing problems unless you have only the experts do it. And if you have only the experts do it, which is okay to start, is it for everybody? And it may not be. And some of these procedures, you know, like when you saw Danny do these procedures, you know, routinely in the cases that he showed. But that's not a routine procedure. Opening the flap, doing the graft, harvesting the bone, going up onto the, you know, the nasal septum. You know, these things are, you know, can be done for an experienced periodontist or oral surgeon. Yeah. Most periodontists or oral surgeons should be able to do those surgeries. Not all general dentists can do it, and that's part of what we have to face. Do some of them, some of you, if you're general dentists, have that ability? Without question. Some of you have developed enough skill and have apprenticed enough and have taken enough courses that you can do that. No question about it. But who's to decide? So many mistakes. We see so many errors. I know Danny and I both have lectures on repairing of defects that other people have created. You saw us a lot today. It wasn't our focus, but we have a whole lecture of how to deal with problems. Over 65% of our patients that I see in the office today for consults are redo of other people's implants. I'm not talking about, you know, redo of a crown. I'm talking about redo of their implants, and they have either a cosmetic problem, peri-implantitis problem, malposition. It's one of those problems, and they want it redone or have to have it redone. This is a major thing that we have to deal with today. And it's going to get worse. It's not going to get better. If you look at the article by Dirks, this was that interesting paper that everybody talks about, the 9-year study by Dirks and a group in Sweden. And they looked at the success rate of implants done by specialists versus generalists, and implants prosthesis done by generalists. The prosthesis, you know, which you assume that every dentist could, you know, do the crowns the same. Well, it's not. If they were done by prosthodontists, there was an odds ratio of almost 4 times greater problem with the general dentist doing the restorative work. Now, this is something that is a taboo. Nobody wants to talk about this. But it's time that we truly face what level of training is necessary before you know, go out and start practicing implants. Because you can do a beautiful crown on a tooth doesn't mean that you can do a beautiful crown on an implant, especially if the implant wasn't placed by somebody, whether it be you or somebody else, that was placed properly or into its ideal position. When it was placed ideally, everybody looks like a great restorative dentist. When it's not placed ideally, it changes everything, and that's part of what we have to face. So I tend to agree with Danny on this. I tend to agree with Danny on this and really just feel that it's very hard to do randomized control studies on procedures that are not really that validated. They're still early, even though we see a lot of experience today on the podium. They're not that experienced clinicians around the world doing these routinely. Yours is probably the most standardized one because you've been doing it for so long and having such great documentation.
Yeah. But look, that also shows, I mean, this procedure is now 20 years old.
Yeah. Yeah.
First 6-8 years were a trial phase, trial and error to establish the protocol. And the study we have now published, we started in 2005. Took us 12 years to collect all the data and now publish a 10-year study. And that shows that you cannot do that just within, let's say, 12 months or so.
Right.
So it's a lot of work.
It's hard. Very, very difficult.
But it hasn't stopped anybody doing the technique.
Yes.
We understand that. There's a reality of finances involved. Let's talk about reality. And people are thrown out into the real world. Listen, in the United States, as you know, we have mostly specialists transferring back and forth cases with the generalist and with each other as other specialists. However, most of you, if you're out from out of New York, not New York, from outside of the United States, you're expected to do everything. You're expected to do everything in your office. Nobody sends anything out except if some extreme oral surgical case or something to a local oral surgeon or a hospital. So you're expected to do everything. Who taught you how to do this? When I go to Europe, I say, well, you're doing sinus. Did you learn it in school? No, we didn't do any in school. You ever did not one? Did you do one in school? No, I didn't learn how to do any of them in school. I learned afterwards. I took this course, and I took that course, and I learned this way, and I saw Dental XP, which is why we have it. It's the reason that we have Dental XP is for that. Oh, I looked at it under, but nobody was over your shoulder when you were doing it. And as a teacher for 40 years, I will tell you there is a difference when somebody's over your shoulder. No matter how many articles you read, and no matter how many things you've done, are you still a top expert? Some of you do become that by repetition and by really going to multiple offices and learning. Others are not. And I think this is an odd thing to say, but you have to face your own, look in the mirror and face your own reality. what should you be doing and what you should not be doing. And that's why your SAC, you know, the simple, advanced, or complex, whatever, is very important. What should you learn to do and when should you do it? And you know, when I teach a basic course in implant surgery at Columbia, we run a 12-day course. It's not a 2-day course. And it's for people who have no training yet in doing surgery. And it's not a 2-day course. You know what half the course is? Learning which cases you should never touch yet. Not just which ones you should do and which ones you should stop, but which ones you're not ready for yet. You're not ready for certain cases, even though you're taught that you should be able to do everything. As a generalist in Europe, in Asia, in South America, you're doing everything. And I have great respect. It's very difficult.
Don't give a lecture here.
Okay, I'm sorry.
Please, to moderate.
It's very
Okay.
difficult. All right,
So,
I'll be quiet. I'll be quiet.
The next,
Thank you.
well, I heard each of you, I heard each of the teams refer to the technique as minimally invasive, but they involve different procedures. Can you comment about the level of invasiveness of the procedures? And because obviously some involve flaps, some don't. Yep. Can you comment on that?
Yeah, I mean, I'd like to make a point on that. I actually not only tried, I was involved in 2 or 3 of the articles in SVG, in Dual Zone, and now in PET. So in a lot of ways, I don't know where I stand. I was involved in it early on because Stephen was nice enough to show me his dilemma, and I actually had a similar dilemma. This is where this all started for us. And while all this was happening, we tried to attain information with Dennis and his group, and with our group in Atlanta, and obviously with Hane and so many others that were involved in this study. It evolved for me, and I started seeing a few things that I was uneasy with. And I remember then going to the discussion of maybe we can put soft tissue in there to enhance that soft tissue zone, and therefore, you know, the addition of soft tissue in the tissue zone evolved for me with my Italian friends, the Agninis. And of course, during that whole thing, it became this confluence and this direction towards partial extraction therapy. And so it's not a study, but I would say that just simply I saw that there was a trend towards going more and more minimally invasive, and from completely incisionless to tunneling and adding tissue in the tissue zone, all the way to just simply going back to not trying to put much at all in that space on the labial and retaining the root. So all of them require, even though we would think because it's not an incision, it's minimally invasive. I'm not so sure as a surgeon I would agree. And having done all of them, all 3 of them, I would say that they all require a skill, a set of skills, a standard, a different armamentarium, different concepts. And I think all of us have to be very honest with ourselves. I think Danny has been one of those voices saying, hey, you know, don't learn this stuff on social media. I couldn't agree. I think Howie would say the same. I think you need to go and this is completely different concepts and techniques that you may not or have not tried before. Go learn it, but learn it definitively. Don't learn it in a day. Learn it and learn the new concepts and techniques, and do it slowly. Always know that there is a protocol in identifying the correct patient and avoiding the higher risk cases. And I think that I think all of us would agree to that.
I think I agree to some degree. Partially extraction.
Partially agree?
Partially agree. And I think it's something that you and I have discussed a lot, and certainly there's been a lot of debate about social media and whether social media is something that we can utilize as a platform for teaching. And certainly there's no doubt in my mind that proper training is the right way to go. But unfortunately, we don't live in an ideal world, and we have a lot of people that are looking at social media to get their information. And I think as opinion leaders in certain techniques and things that we do, I think it's our job to put that information out there, because social media is the way that things are going. You know, that's where people learn from, and we need to use that technology in the right way, not try and control it, because we can't control it. You know, there's almost like a self-control, because if you put something on Facebook or wherever you put it that's absolutely out of the park, you are going to get slated. I mean, there are guys that it gets quite rude and actually quite obnoxious the way some people take you apart. And I think we just have to trust that, and I think we have to share on social media. I think it's important that we give people the information on social media, and that way we are doing our job rather than trying to force people to come to courses which they're just not going to do. That's just the reality of things. So we have to try and make things, we have to do things properly.
Yeah, but I use social media in particular to advertise people to attend courses, and I try to provide information that is actually very conservative and not encouraging people for procedures that are not documented. I think when we talk about minimal invasiveness, I would fully support that, but this is part of my secondary objectives. And therefore, you see, and we've made a lot of progress in that field, but I still believe that the big majority of implants need to be placed with open flap procedure. If I can do the procedure in one open flap, then I'm much better than 2 or 3 open flaps.
I agree with you 100%.
Okay, that means we should stop to tell people, now everything, I mean, we have had that 15 years ago with Mrs. Canepa, teeth in an hour, everything flapless. And we see all the bullshit now with these infections, all these implants outside the bone. And this is a problem, you see. Most of the implants need to be placed with an open flap procedure, and we try to gradually increase the percentage of flapless when we have the evidence. Yes, it's very predictable. And therefore, I'm very happy for this socket shield technique, that the group is pushing that forward and establishes the evidence. We are not there yet, but I think it will take some time. And when we know exactly the inclusion criteria and when to use what, then I think this will be a very important additional technique in our whole armamentarium to treat our patient pool, you see. But it will not be the number one, or let's say the single one, that nothing is the single one.
There is no single one.
I completely agree with you. Danny, I think that if there's one consensus, as I would tell you, I completely agree with what you said. I think that social media, the internet, things like that should expose you to new concepts, but it should not teach you new concepts. I think that it's an opportunity to share some things, but it's certainly not an educational forum other than for discussion and exposure. I think formal education in those procedures is warranted. So maybe there's a little bit of that needs to be done. And I do believe, as you just said, that before you can get into some of these procedures, knowing a basic flap technique and doing basic surgery, which most implant cases require, basic information, basic education. So some people come to me and say, I just saw I can do sinus lifts through a crestal approach. Well, I usually tell people, but before you ever do a crestal approach, you should be able to do it through a conventional lateral approach. And before you can do an incisionless case, you should be able to do 100 incision cases where you've exposed the bone and see what it looks like and drilled an implant. I think that doing minimally invasive therapy without first understanding how to do maximally or at least moderately invasive procedures is not warranted.
Okay. So Dennis, how do you respond to the fact that all surgeries should be at least should be considered with a flap? Because you emphasize quite a bit about flapless.
Let's not confuse two things. I talked about flapless for extraction sockets.
Yes, exactly.
Don't confuse that with flapless surgery to a healed ridge. Got that? Two different things. So I'm talking about flapless for an extraction socket. I feel that everything is right there for you. You know where you are, especially if you're an experienced surgeon. However, that's totally different than if you have a healed ridge that you think you know where you're going. And there was one very good article, what is it, Van de Velde, what was his name? I think it was De Bruyn's group, where they took a ridge, they took a typodont that had enough bone to put an implant in. It was a typodont, a plastic model, and they gave dentists a CAT scan of that model on your hand, okay? And they said, okay, this model it was a edentulous ridge, this model has enough bone to place it. It would be within it. Placed it flaplessly. And they gave it to surgeons, and they gave it to general dentists. And what was interesting is that, you know, over 50% of the cases were dehisced, even though there was enough bone to place it. That's why I totally agree that don't confuse flapless surgery when I'm talking about flapless extractions. That's completely different than a healed ridge. I totally agree if you have a healed ridge, go and open the flap. That's without question. So don't confuse those two. It's a big difference to me.
Yeah, and extraction socket, single-rooted and multiple-rooted is
Single-rooted.
another different story.
We didn't get there. We're doing a lot of now immediate molars. You know, we have the southern implant that that's it now. Now Megagen has it, and so does Keystone. Yeah. These are the companies. You go look at them. These are the ones that we're doing. We just did a study on our own office of over 250 that we placed, and we have a 95.5, 95.7, I think. It was 96 percentile success rate. And Richard Smith and I were working on this with our partners, and there's no question that this is there to stay. If the buccolingual walls are there, we're placing immediate symptom molars. We didn't even get to that today. We dealt with the aesthetic zone. It's a whole separate topic, which I think is going to increase with time, but with the right hands and the right cases, like anything else like we spoke about, that we can do this and go wider instead of just apically, which you can't go, because of the nerve or the sinus. I think I said.
I would disagree with the wider. I have to be honest. I mean, we spoke. I mean, obviously you're going with the maxi. We did a lot of the narrow with the ankylos using the 3.5s, and we did about 150 of the 3.5s, which went because obviously the 3.5s with the ankylos got a good Morse taper, so you have a different connection to the maxi because the maxi.
So what are you saying? What don't you agree with?
It worked very, very well.
Well, if you have the bone, we use a narrow one, sure. If you have the bone, do regular implants.
But you could actually get good primary stability in the furcation quite well.
If you can. In the maxillary molars, first molars, that's true. Second molars, very unlikely, because the roots are fused higher, and you don't have the bone, the septum in the middle. And also in the mandible, when you drill on the septum area, you definitely sometimes drill the septum away if it's too thin, and so then you need to go wider. And the average width in that area is between 7 to 8 millimeters, where the furcal bone comes in, and so the average diameter is about 8 millimeters there, and that's why we use the most standard implant that we have to use when septum is gone is probably the 8 millimeter wide implant.
The problem that we see with that, obviously being from South Africa and using a lot of the maxis, is that the wider you go in molars, when you do an extraction, we know that molars collapse more so than anywhere else, and a lot of these wide diameter implants. This to me is the biggest fallacy
of all. That's due to the Schrapp article.
I see it. Well, I don't think it's a fallacy.
We don't, and we've been doing it now for 5 years. We don't see that because we don't open a flap to take any molar out. I'll repeat it 6 times. We don't open a flap to take even a molar out that has even broken root tips. Everything is done through the opening. Yes. Everything. And thank you. And I've been doing that since
we do the same way.
20 years. But if you do what Schrapp did or others, where they open the flap, yes, you're going to see much more bone resorption. If you don't open the flap, you don't see this kind of bone resorption, and I'll show you case after case documented every week and then for up to a year, and you don't see it.
I think we're going in a different direction, Dennis. We're talking about molars. I think most of our discussion today was about anterior ridge.
Right, but it did come up, but I think...
Yeah, no, I'm just saying, I think that it's just, I obviously believe that that's another debate on another day.
It should be.
Yeah,
but the evidence doesn't always bear that out about the role of flap, because most of the studies have shown that yes, initially, there is a difference between flap versus flapless extraction, but after 6 months, you will not be able to distinguish flap versus flapless in terms of the amount of bone.
Depends on which articles you quote. There are some that show this, exactly what you're saying, I agree, and some show a huge difference in terms of bone loss. And, if you go and look at this literature, the ones with flaps in general, not all, but in general show a much greater trend, and that's because we're interfering with the extraction also. That's because we're placing it with the extraction of taking away the buccal periosteum, as we discussed before, and you're taking away the ligament blood supply. The bone is by itself. If it's thin, it's going to resorb.
I was surprised, though, when I looked at that particular area, and it's good. It's nice that you brought it up, is that most of the research showed, when it compared flap to flapless, does not entertain grafting in the flapped cases. And I never could understand, is anybody in the audience would raise a flap to extract a tooth and not graft? Is there anyone in the audience who would raise a flap and not graft? So the fact that they have studies where they raised a flap, extracted a tooth, and put the flap back, didn't graft, and compared it to a site where they did an incisionless extraction, to me, makes no sense. It would be more realistic to a clinical situation, at least, Danny, I would believe it, if they extracted a tooth with a flap and grafted and compared to the non-grafted, non-raised flap and extraction sites. I mean, that would give me more clinical information. Hasn't been done.
Yeah, but look, this is again biology. When you raise a flap, you're going to remove the blood supply from the periosteum, and you get additional resorption. That's as simple as it is.
For sure.
And we know that it's about 0.8 millimeter of the outer side of the cortical bone is blood supply from the periosteum.
Yeah.
When you have an extraction, you have inside an extraction, you lose the blood supply from the periodontal ligament from the outside. Not a surprise that you get more bone loss in the initial stage. And therefore, I think flapless extraction must be the absolute standard of care, you see. That's what I teach my postdocs for 15 years now.
Well,
There's a good paper by
Mariano
Queerman.
Sanz's group did the study doing the grafted versus non-grafted with a flap, and they found the difference only in the cases of a thin wall.
Yes.
So where there was not grafted in the thick wall, it didn't make any difference. The grafting of
What
the
Danny showed, sure.
right.
There's a good paper by Queerman on humans that came out last year. I'll email to you. They looked at the different groups, and that's really the first paper that says there's a difference.
If you want to see
Actually, because it would be interesting, Stephen, when you guys, you and Guido and Dennis showed the type 2 and type 3 cases. I mean, those are, I assume you have no labial plate, so it's not, periosteum isn't providing you any source of
No, we did GBR.
blood supply. Yes,
We did GBR.
that's what I'm saying, but it's a time of extraction, even though it's incisionless, you're performing a bone graft without periosteum being there. And the reason I say that's interesting information to achieve, Danny, is just that you are correct. We have a lack of source of blood supply to that area, and it's going to resorb. Wouldn't it be interesting just to be able to simply do the study, even on an animal study, to simply graft and put a membrane and do it at the time of a flap and compare it to an area where you didn't do a flap? It would be, I think, how many in the audience would like to know whether or not that actually would collapse as much as a non-flap case?
It's actually
I know
been
I would.
done. It's actually been done. Look at Lekovic and Kenny's work. It was probably one of the best groups of papers on, it was with guided tissue regeneration with and without membranes. They did it with first resorbable membranes and then without non-resorbable. And they did maxillary anterior teeth, extraction 6 anterior teeth, and they opened the flap in both cases. And in one case, they just pulled they cleaned the defect out, they put markers in the bone, and then they did primary closure, made measurements and put primary closure. Reopened in 6 months, and then measured the buccolingual thickness. What was their measurement? 4.2 millimeters average. 4.2 millimeters buccolingual change. That's with an open flap, no graft, no membrane. When they put the membrane on, Gore-Tex or the resorbable one, I think it was Resolute or whatever it was at the time, they put a resorbable membrane and they got similar results. What were they? About 1.2. So it was really very, very minimal change if they did GBR. So there is some data on that. And the Lekovic and Kenny group out in California actually showed that.
Right.
So if you want to know what happens if you just open a flap and do primary closure, hike it up, clean it out, and then pull it over, they did it twice and got the same results twice with markers.
Yeah, but I think we have an agreement. We don't do extractions with flaps, huh?
No.
Because
Right, okay.
we don't have to
I
discuss
know,
it
but
further, you
that's
see.
done already. That's why we don't do it.
So-
Because articles like that that make us don't do
The
it.
other point is, when you do flapless extractions, then you also have a chance to regain the keratinized mucosa. When you do a flap and then you do a primary close, you're going to lose all the keratinized mucosa. It's a big that's a big mistake to do that. You see, we did that 25 years ago, and then we learned the hard way.
There's
But
no
I think we have a right corner here, a prosthetic corner. Don't you have any questions for them, you see?
No, I think, Homa, your question about minimally invasive, I think it really goes back to what Urs and Danny had said, what is the efficacy of the outcome?
Right.
How many surgical interventions are you going to do? And what's the aesthetics and safety to the patient?
Right.
So you have to determine that, we talked about one surgery one time in specific cases, but there are plenty of indications that we have to do multiple, or the surgeon has to do multiple surgeries to achieve the goal that they want. So like the other groups outlined, they outlined clearly when would they do the other techniques. So I just think it's minimally invasive would be how many, could you provide the least number of surgical interventions to accomplish those goals?
Well-
So if you had the ability to do it, say, in one surgery versus 5, but you could have the same outcome, then I would say I would prefer the one, and the patient would do it too.
Yeah.
But some cases need a lot.
I have a question for you and Urs, because I was watching, obviously, Howie and I are not restorative-based dentists, so I was wondering, when I saw some of the work with Danny that you guys did, delayed approach, when you uncover the amount of time for Urs to reshape the tissue. See, Stephen and Dennis were doing it immediately and maintaining the contours with either an immediate temporary or using the eye shell. How many visits for Urs to redevelop and gain the contours for that restoration and to redevelop it?
Yeah, I think that's a very important one. I think I mentioned it, that I want to reach the goal with a maximum of 2 sessions. There's one session where I place the temporary restoration. I am somebody who is convinced that we should be rather slim when we put this in. I don't want to see this excessive blanching and thinking then that you can push the tissue exactly where you want. It's an illusion for me. And go slim, I wanted to see the patient back in 2 weeks, and then I make one modification on the emergence profile, and that's it. And then I have to reach it. I think we have overemphasized the contribution of the restorative dentist in creating aesthetic peri-implant soft tissue contours. You get it almost automatically. If the implant is correctly positioned, probably we could also get the job just with a healing coping, something like that. Ultimately, we would have, but I need it on centrals to give the technician also a chance to give it a try with a temporary to see what would be really this, and then I let it wear the patient half a year normally.
That's
because
precisely the point, that the implant position is the key.
Yeah, of course.
And all of you guys are
Absolutely.
really fantastic surgeons. But these are very difficult situations. Every 3 of the situations that you described, whether it's an early placement into a partially resorbed socket or full socket or in conjunction with a root shield, these are very challenging implant positions.
Yeah.
So based on what you said about the average Joe, which of the techniques do you think is easier for the average Joe to be able to implement in their practice?
That's a good question.
So first of all, when I heard Stephen to say this is a simple case, and it was an immediate, I think I completely disagree. None of these procedures is simple. Most of them are complex, in particular when it's a flapless approach, because then you are digging in the dark, and you need a lot of experience and gut feeling to do a good job. I have seen him to do 3 surgeries in one day, and you could see the experience, you see. You could almost do it with closed eyes, you see, just boom, boom. But that is not simple. This is only looks simple because he's so experienced. Yeah. So I would say these procedures, and I'm sure the same with socket shield, is not a simple, straightforward procedure. That's more a complex level because it's also flapless, you see. And therefore, I think it's either advanced or complex.
I think there you make a good point. I think complex may be a little bit too far.
Okay.
Because I really think that's pushing it too far. Yes, it's a intermediate, advanced type of thing that requires a certain amount of skill, as does socket shield. But I think because ultimately, if you're going to raise a flap and put the implant in, the bone looks the same as it did when things were not raised a flap. And we have guided surgery these days. So, I mean, why not, under the right circumstances, if you have a concern, why not teach your students to do guided surgery with flapless implant placement if the situation is right, if your bone is right, your soft tissue thickness is right, etc., etc. Should it be a complex case? I don't think it's a complex case. I think it's an advanced case.
Okay, you see, I fully agree with guided surgery, but and that's what my postdoc students are learning. But don't you think that this is solving all the problems? I always tell my postdocs, you go for computer-assisted surgery, please don't turn off your brain. Because I see in the cases I do that 20% of the surgical guides cannot be used.
100%.
Because they're not precise enough. So you have to recheck, you have to be very conspicuous that they are good enough. And then to do that flapless without self-control, then you end up somewhere outside.
You know, I'd like to get back to the restorative phase. And Stephen, please, go ahead.
Yeah, I think, Maurice, what you're alluding to is that if we're using an immediate protocol, that we have the ability to maintain the tissue profile at the time of surgery. So that's why we like that. But if we do it as a delayed protocol on a healed ridge, I completely agree with hers that we have these flat contoured healing abutments, and it gives you the ability to then go back and sculpt the tissue either in 1 or 2 visits. And it also depends on, contour is strictly a function of implant placement. You have bad placement, too far forward, you have to under contour. If it's on the palate, you may have to have, convex contour. But I think Maurice's point is well taken, is that could we do something that would minimize then having to go back and do other procedures if we didn't do it the first time? So with the immediates, we like doing that because we can do it at the first time, but definitely in the cases that you're doing the early delayed or intermediate, those are delayed sites, and we use flat contoured healing abutments, and we go back and sculpt the tissue because we need to.
I would tell you that you and Urs are remarkable prosthodontists, and you're not the average. I'm sorry.
Don't be too positive now. You see,
And I'm not trying to bash David, Garber, or Henry, but it takes them more than twice to get it right. I saw David 7 times, and he was never more proud. He took about 280 pictures of how he sculpted the tissue with his temporary. He was proud of the fact he got it done in only 7 more visits. That's it. Now the fact is that was a great case for about 2 years, and then it slowly collapsed. And a number
It must have been a surgery.
It must have been the surgeon's fault. But also, I want to make this point because a lot of times it's the multiple opportunities that you have to go back and forth to the head of the fixture. When you're going in and out, in and out, in and out, in and out, in and out several times, and I have to say, if you and Urs do it twice, then most average people are going to do it more than that. And I think that constant manipulation of the prosthetic parts in and out may in fact cause bone loss and lead to detrimental implications. I've seen it in my office, and I think that's not as simple as we think. So the restorative phase is critical, and with partial extraction therapy, we found that out in the hard way. Most of the internal exposures you saw were older cases where we didn't understand the importance of placing the implant more lingually and of making that S shape of the abutment.
So,
I think it's very important, just one last part of this. Even with the minimum of 2, which even the 2 experienced highest level prosthodontists are saying they take 2 minimum visits if you have a straight healing abutment to sculpt the sulcus properly. That's minimum. That's a half-hour visit each. Take the temporary off, redesign it, add acrylic to it, squeeze it in. Sometimes anesthesia might be necessary even. That's a half-hour visit, I guarantee you, in your chair. You measure how long that patient's sitting in your chair. What could you do if you had, that's an hour of your time. That if it was an immediate extraction socket, that's why we at least want a custom healing abutment in there. And I think in the future, whoever's doing the surgery, for yourself, if you're doing both, or a periodontist or oral surgeon, I think if you're going to do an immediate implant on an immediate extraction socket, I think it's going to be mandated, if they want to be busy in the future, to take 5 minutes to at least do a custom healing abutment. Maybe most surgeons won't want to do a temporary, but to do a quick flowable composite around something like the eye shell or something like it, just to make a custom healing abutment that saves the shape of the tissue, you've saved your restorative dentist 1 hour minimum of time.
And you're a
Steve,
hero.
Unbelievable.
Steve,
You're a hero.
have you ever used your eye shell for custom impression coping?
He sleeps with it every
Yes.
night. What do you mean? He uses it everywhere.
Yeah. Well, I want to go back to Danny's comment where, we're really, Urs and I are very lucky that we take a lot of things for granted, and I think it's a two-way street. Bad prosthetics can kill a great surgeon's surgery in 2 seconds. And, and a bad surgeon can make our lives miserable and a nightmare.
That's how we met.
Right, exactly. That's a true story. That yes. So, but Danny, you're a very talented, gifted oral surgeon, and you make the second part of augmentation look easy, and it's not sometimes. You make it look really easy. So the whole point is that whatever is in the wheelhouse, some of the cases that we see as failures are those individuals that are not able to do the second phase of your technique, which is augmentation.
Yeah.
But, you do it like it's nothing, but for some people it's really hard, and we see them as failures. So,
if I can say one
just-
point, I think one point that should be introduced into all dental schools is that all surgeons should be involved in the prosthetic phase at a temporary level.
At some point.
We're doing that now.
Every single one of them should
We're
know
doing
how to
that
make
now
a
in
temp.
Columbia. We're doing that.
Without a doubt.
But the homeless question, can you use the eye shell for impression making? The answer is yes, because what happens is that it's the same preformed part. So all we have to do is take it out of the box, put it in, because hopefully there shouldn't be very much shift. And the problem we have with impression making is the minute you remove the provisional, the tissue's collapsing. But you have the same part, and you can put it in around the, implant level impression coping or whatever, or even code the surface so that it's pretty much identical. So it can save you time.
Now, one thing we have to also consider, we haven't discussed, is that from the patient's perspective. In any of these studies, these are patient-reported outcomes are very important. Now, patients are not always honest with the surgeon, but maybe they'll come back to the restorative dentist, give some feedback. Have you give feedback about these different approaches from the patient's perspective? What has the feedback been?
I mean, I would have to believe, I'm just going to jump in here. I would have to believe that dual zone, SVG, and partial extraction therapy, the patient's memory of it is going to be quite good. Maybe with additional soft tissue grafting, they'll remember a tissue harvest or a little bit more swelling and edema. But I would think that dual zone and partial extraction therapy are really almost identical procedures from the patient perspective. I wouldn't think that there's much difference in it. And also from the restorative standpoint, how important it is to maintain the shape of the tissue during the healing phase, which avoids having to reconstruct it later on, which is multiple visits, as David said, as Dennis said, maybe multiple stages with anesthetic. And then also, I mean, I don't know, I have stuck with a patient before Christmas time, one of David's, and he promised to make her a temporary, and then he left town to go to South Africa. And I don't know, it wasn't so easy for me to add all that contour, and I don't know how much blanching is acceptable, should I do more or less, and it wasn't so easy, at least for me, so I'm just saying that it avoids that.
You mean the relationship with, pros and surgery, I think Sonia alluded to it this morning, Herrenbrahm, because there's always that tug of war that, we as prosthodontists always want the surgeon to do the maximum amount. But the reality is it's not so easy sometimes. So as Urs had said, it was a big circle saying, we can only do as much as the surgeon, but that's really the reality. So that's why I always tell dentists, could you do this for me, or could you do that? Maybe I'm a pain in the butt sometimes, but the bottom line is that I'm only as good as what the surgeon can do for me. That's the reality. Yeah. And if I don't do my part, I can mess up the surgery as well. So,
Danny, can you comment on multiple extractions? You didn't really discuss about multiple extraction with the early placement approach. Can you comment on that?
Okay, so I fully agree what I think one of the speakers said. When you do a series of extractions next to each other, you're going to get much more tissue alterations than a single tooth extraction. Mm-hmm. So when I get a patient and I see, for example, there will be a 4-unit extended edentulous case, I do often actually the Bördner-Langer technique. I try to figure out where are my 2 spots where I put implants in, and then the 2 other ones I can cut down and submerge them and let them heal.
You're submerging roots?
And
I do that for 15 years.
Come on, Danny.
I do that for 15 years, you see. And then what we actually then do, when we do the implant surgery, I put into the early sockets the 2 implants, take the roots off and do there, and socket grafting with membrane.
With flaps?
And that a flap, yes. And then that gave us really good results. But then we try to avoid adjacent implants. Mm-hmm. So then we have always a pontic area, or sometimes we have a cantilever unit.
I agree with that.
Yeah.
Pontics are good. Pontics are good.
Because in pontics area, you can regain actually vertical height, 2-3 millimeters. I have several 10-year follow-up cases we did not show today that shows excellent maintenance of height. And of course, the papilles are slightly blunt. But I think patients are very pleased because very stable results.
You just made David Garber's day.
That's right.
He's a Pontic lover.
He's a Pontic lover.
Yes.
Yeah, that's why he's a nice guy.
All the restorative dentists.
I think as exciting as this panel discussion is, I think we've come to the end of it.